Hi there, nursing students and future nurses. Here are two questions that give a lot of information regarding DKA and HHS. So let's look at the first question. The first question is a nurse is caring for a 29-year-old client with type 1 diabetes who presents to the emergency department with symptoms of severe fatigue, abdominal pain, fruity breath odor, increased thirst, and frequent urination. Vital signs reveal a heart rate of 115 beats per minute, blood pressure of 90/60 millimeters of mercury, and a respiratory rate of 28 breaths per minute. Lab results indicate a blood glucose level of 340 milligrams per deciliter, serum bicarbonate of 14 milliequivalents per liter, and a blood pH of 7.25. What is the nurse's priority intervention? And so when we're answering these case scenario questions, especially as we do on a nursing exam or on the NCLEX, it oftentimes revolves around prioritization. So for this patient who is presenting with signs and symptoms of DKA, do we want to give the patient insulin? Do we want to start an IV line and give the patient fluids? Do we want to give the patient oxygen since the patient is breathing rapidly? Or do we want to arrange for an ABG to assess the patient's respiratory status? So we want to dissect this question and break it down into ABCs: airway, breathing, circulation. That's one approach. So let's look at the patient's vital signs. So the vital signs, the patient is tachycardic, and that's because the patient is dehydrated. When someone is dehydrated, heart rate will go up. When someone is volume depleted, heart rate will go up to maintain cardiac output. Cardiac output is equal to heart rate times stroke volume. So stroke volume has an inverse relationship with heart rate. And so when stroke volume drops, heart rate will go up. And so this patient is tachycardic to compensate for the volume depletion and the low stroke volume. Blood pressure is also reflective of low volume. The patient is hypotensive. And the patient is breathing at a rate of 28 breaths per minute because the patient has a pH of 7.25, which tells you that the patient has metabolic acidosis. And so to compensate for that, the patient has to breathe faster and deeper. And that's Kussmaul's respirations, right? Hyperpnea is breathing very deeply. Tachypnea is breathing very quickly, and together it's called Kussmaul's respiration. So this patient is blowing off CO2. While they're blowing off CO2, they're also blowing off water, and so they're losing fluid in respirations as well, right? Remember, CO2 plus water is carbonic acid, and that's how the lungs get rid of acid. So what is the correct answer? The correct answer is to start an IV line and administer isotonic fluid. So here are the rationales. So for A, administer an insulin bolus to rapidly reduce blood glucose levels. Although insulin is essential in treating diabetic ketoacidosis, it is not the first priority in this instance. The client's symptoms, including fatigue, hypotension, tachycardia, and acidosis, suggests that the patient has severe dehydration caused by what? Osmotic diuresis from the significant hyperglycemia that the patient has. So fluid resuscitation is necessary to address this dehydration and stabilize the blood pressure before starting any insulin. If insulin is given before adequate fluid resuscitation, it can lead to rapid shifts in electrolytes, particularly potassium, which can worsen dehydration and potentially lead to hypovolemic shock. Therefore, fluid therapy should be initiated first to support blood volume and circulation. Once rehydration is underway, insulin can be introduced safely, and the sugars will be coming down anyway because volume will also help gradually bring the sugars down even before the person is given insulin. But once rehydration is underway, insulin can be introduced safely to lower blood glucose levels and stop further ketone production. And that's the goal. We don't want the patient making ketones because the more ketones they make, the more acidotic they get. B, the correct answer. Fluid resuscitation, again, is a priority intervention in managing DKA. and this is due to the severe dehydration associated with the condition. Hyperglycemia in DKA leads to osmotic diuresis that causes substantial fluid and electrolyte losses through polyuria, the increased urination. The symptoms and lab findings, such as hypotension, for example, and tachycardia, and the low bicarbonate, indicate that the client is experiencing intravascular volume depletion. So the patient is dry, and so they need to be rehydrated, and we rehydrate with isotonic fluids such as normal saline, which will help restore the blood volume, will help bring the blood pressure up, and it will enhance perfusion to vital organs. Fluid resuscitation also, again, indirectly will lower the blood glucose level by improving renal perfusion, which then will promote glucose excretion in the urine. So again, fluid resuscitation or administration of fluid in an aggressive manner is essential before administering any insulin, as it stabilizes the client and prevents rapid shifts in osmolality that could exacerbate electrolyte imbalances, particularly potassium. Rehydration is the first and most critical intervention for stabilizing the client's condition in DKA. Now, how about oxygen? One might be tricked into picking oxygen because the patient is breathing rapidly. Don't add any extra information into the question. There is nothing in that question that tells you that this patient is desaturating. And again, oxygen therapy may appear necessary due to the rapid respiration. However, when patients are in DKA, tachypnea is usually due to Kussmaul's respiration. And this is a compensatory mechanism for metabolic acidosis, allowing us or the patient to blow off carbon dioxide and reduce the acidity. This respiratory compensation is a natural mechanism and does not indicate hypoxia. It is compensation. Therefore, oxygen administration would not address the underlying issue. The primary treatment for metabolic acidosis in DKA is to do what? It's to correct the dehydration and the hyperglycemia through fluid resuscitation and insulin therapy. As the blood pH normalizes with treatment, the respiratory rate should improve without the need for supplemental oxygen. Thus, oxygen therapy is not a priority in this scenario. Lastly, D, arrange for arterial blood gas analysis to assess respiratory compensation. Although an ABG can provide useful information about the patient's acid-base status and the degree of respiratory compensation, it is not the immediate priority in the acute management of DKA. The client's clinical presentation, the fruity breath, the elevated blood glucose, the low bicarbonate, and the low pH clearly indicates DKA with metabolic acidosis. So immediate treatment should not be delayed waiting for ABG results. Fluid resuscitation and insulin therapy are critical, again, in managing DKA and stabilizing the patient's condition, and these interventions should not be postponed. Once the client is stabilized with fluids and insulin, then we can do an ABG later on to assess the effectiveness of the treatment. However, given the clear signs of DKA in this scenario, it is more crucial to initiate treatment promptly than to wait for further diagnostic testing at this stage. The next question says, a nurse is caring for a 72-year-old client with type 2 diabetes who has been admitted with extreme thirst, dry mucous membranes, and confusion. The client reports feeling weak for several days. On assessment, the nurse notes a heart rate of 110 beats per minute, blood pressure of 95 over 60 millimeters of mercury, and deep labored respirations. Lab results show a blood glucose level of 680 milligrams per deciliter, serum osmolality of 340 milliosms per kilogram, negative serum ketones, blood pH of 7.35, and serum potassium level of 5.1 milliequivalents per liter. Which of the following interventions should the nurse prioritize? Again, this is a prioritization question. And so we'll look at all the information that's given and then decide upon what the patient might be presenting with, and then we can come up with a plan for an intervention. So one key thing that gives you a clue as to what this patient is presenting with is the fact that the patient has a very high blood sugar, a very high osmolality, well, not more, this is more than one, and the patient has no ketones in the urine or no ketones in the ketones in the blood. And so this clues you into the fact that this patient does not have DKA, but instead they have HHS. So let's see, do we want to give a bolus of regular insulin? Do we want to start IV fluids? Do we want to give the patient sodium bicarbonate? Or do we want to arrange for continuous cardiac monitoring? Well, let's just look at the scenario again that's given to us. This patient is very dehydrated. Look at the serum osmolality. 340 is pretty high. The patient is tachycardic, which tells you the patient is dehydrated. Patient's hypotensive. Patient's volume depleted. Look at the blood pressure, 95/60. The patient has dry mucous membranes. So you're assessing your patient, right? The first step in the nursing process. Patient's extremely thirsty. The patient is having neurologic symptoms. The patient is confused due to fluid shifting in the brain cells. And so what is the priority? Well, the priority is to administer a bolus of fluids. So we want to aggressively give the patient fluids. So we want to start an IV line and begin aggressive rehydration with isotonic fluids. And so the correct answer would be B. The primary concern in HHS, again, is the severe dehydration. And again, you can tell the patient is severely dehydrated based on all those symptoms I just mentioned, the extreme thirst, the dry mucous membranes, the hypotension, as well as the lab findings of a high blood sugar level, as well as a high serum osmolality. So fluid resuscitation with isotonic solutions is the most urgent intervention and the most priority. So in giving fluids, it will help stabilize the blood pressure, it will help restore circulation and perfusion, and it will also reduce the blood glucose level, again, by improving renal perfusion, which prevents hypovolemic shock. And once the adequate hydration is established, insulin can be administered more safely. So giving fluids will reduce blood glucose by improving renal perfusion. When renal perfusion is improved, the patient will urinate more glucose, and giving fluids will also prevent hypovolemic shock. Now, option C is request an order for sodium bicarbonate to address acid-base imbalance. Sodium bicarb is used in cases of severe metabolic acidosis. That's when the pH is low, very low, so 7 or less. And so we give bicarb to correct acid-base imbalances. This client's pH is normal, 7.35. 7.35 to 7.45 is considered normal, indicating no acidosis. So HHS typically does not present with acid-base imbalance or ketoacidosis, unlike DKA. So sodium bicarb is not an appropriate intervention in this situation, and it would not address any primary issue that the patient has, which would be dehydration and hyperglycemia. Rehydration, not pH correction, is the priority for this patient. The next thing is option D. Arrange for continuous cardiac monitoring to assess for potential electrolyte imbalances. Well, continuous cardiac monitoring is beneficial for clients at risk for electrolyte disturbances and arrhythmias, particularly in HHS where severe dehydration can affect potassium levels. However, while cardiac monitoring is useful, it does not take precedence over volume resuscitation in this scenario. And so, again, restoring the fluid balance is a priority intervention. It is priority. And in doing so, it will stabilize the blood pressure, restore blood volume, restore perfusion of tissue, improve renal perfusion, improve renal function. And even though the potassium is 5.1, that's mildly elevated. In some instances, that's not even considered elevated. In some labs, 5.1 is considered normal. So some labs, 5.0 milliequivalents per liter is considered normal. So 5.1 is really insignificant. And so we wouldn't call that an electrolyte imbalance per se, unless it was much higher. And so that's how you break down these two questions.